about the cortical malformations, and we call that the malformations of the cortical development, MCD. And I'd like to talk about that. It's a very difficult subject, but I would like to talk as easy as possible. Okay, so the first, the cortical neurogenesis. And the cortical neurogenesis has three steps. The first one is the neuronal proliferation and apoptosis. Proliferation means increasing cells, neural cells. And apoptosis, in contrast, apoptosis means the decreasing cells. But usually the apoptosis in your mind, apoptosis is a negative term. However, in this cortical neurogenesis, the neuronal proliferation and apoptosis, the apoptosis is for the adjusting the neural cells number. So they need the required process of the apoptosis. So the first step is the proliferation and apoptosis, and the next step is a migration. Migration means the cells are traveling to the cortical plate, the brain surface, that is called as neuronal migration. And then after migration, the post-migrational stage is waiting, the following, and it makes a sulcus and gyrus, the convolution of the brain. And let's compare the mouse brain and human brain. And the mouse brain, here you can see the very smooth brain. However, the mouse has no epilepsy and seizures, right? If the brain of the humans, if the human brain is no gyral formation and the sulcal formation, if that is like a mouse brain, the very flat, the human has the very severe epilepsy and seizures and developmental delay. However, the mouse can run very fast and they don't have the seizures and the epilepsy. So, what is the difference between the mouse and the brain? The mouse has only the first step of the neurogenesis. However, the human has the second stage of the neurogenesis, and especially the big difference between the mouse and humans is the outer subventricular zone. The outer subventricular zone is very focused nowadays, and so the outer subventricular zone, they have the many neurons are created here, and then they are going to migrate to the cortical plate. Now, as I told you, there are two stages of the human cerebral cortex. The first stage, the mouse has a first stage also. The mouse and also the small fetus, they have the same stage, the first stage, and then the second stage. Second stage is very important for humans. This is the only primate specific, therefore the primate specific, the second stage. Therefore, mouse has no second stage. Mouse has only the first stage. And the human has the second stage, and this is a completely different between the mice and humans. And in this stage, this red area on the blue area, the deep cortical layers were created in the first stage. However, the second stage, upper cortical layers with the folding like this, it means the sulci and gyri, they are creating only in the second stage. So the human brain has a folding. And then the transvaginal neurosonography, of course, that you learned a lot about the imaging, neurosonography imaging today, but the transvaginal sonography with the neurosonography is a very, very helpful. And also, here you can see this is the normal image in the coronal section, and you can see here there is the line, the border line between the whiter part and grayish the part, right? So here, this is the between the subparate and intermediate zone, and then the neural cells are migrating from the ventricular area to the surface of the brain, like this. This is a neuronal migration. And there is an inside-out manner. The first cells are inside, and then the second one is out above the first one. The third one is above the second one, or likewise. So this is called inside-out manner. And so here you can see the subparate. I told about the Down's baby. The subparate is thin, and that is a displace. This is a subparate. Now the MCD, malformations of the cortical development, and here the MCD is abnormality in which the cerebral gyrus and sulcus do not form properly. So sometimes, the MCD includes a less gyration, sometimes too much the gyration, okay? So, and sometimes a very abnormal gyration. So MCD case are not so frequently diagnosed prenatally. So why? Because, those gyri and sulci can be seen by ultrasound or MRI or any imaging devices after 28 weeks of gestation. That is a very late pregnancy, late gestation. So it is quite difficult to see the gyration, of course, here. And if the fetus has a gyration and sulci, gyri at this stage in the second trimester, early second trimester, it is abnormal, right? So, however, it is quite difficult to make a diagnosis of the MCD in prenatal period. Now, I had the case in 2008. At 33 weeks of gestation, I had a part-time job in other hospital at that time, and I went there once a month, and I look at this baby's brain, and then, oh my gosh, this brain has less cerebral force, less gyration, less sulcation. Okay, so at 33 weeks of gestation, let's take the 3D. In 3D, this is a normal, many of the gyration, but here this is a less gyration, and take a MRI. Okay, so less gyration. We can call that pachygyria. This is the thick, the cortical plate, and this is completely abnormal. Oh my gosh. However, at term delivery, Apgar score 9 and 10, and yearning and smiling and the sucking milk, no abnormality sign at delivery. However, this child is going to be here. This is at 5 years old, and he cannot sit, he cannot stand by himself, and he cannot eat by himself. He cannot speak, nothing. Very severe handicapped. And then This is the mother, this is the father, this is the second one. Of course, in the second one, she was, the parents were very, very worried, and they came to me to look at the fetal brain. But anyway, this experience for me was very shocking. And then I thought that, that they came to at 33 weeks of gestation, don't they get the hint of this at about 20 weeks of gestation? Because, I was a part-time job in that hospital, okay? So, who looked at his brain in mid-pregnancy? But, I noticed that was me. Oh my God, that was me, I overlooked, right? So this is my, oh my God case. And then this experience, after that, I started the research on MCD. That was my starting point of research on MCD. Now, as I told you, the brain is developing very, very rapidly during the fetal period. And if you look at the brain at 20 weeks of gestation without any, not any, but you can see the very fundamental the structure of the gyrus and the south side, like here, is there, but the not on the surface. The surface is very smooth at 20 weeks of gestation. If you look at the brain at 20 weeks of gestation, can you tell that this brain is growing normally, or this brain is developing into MCD? It is quite a big question and challenging for me. And then, how to detect the MCD during the pregnancy, during the mid-pregnancy, I mean. Enlarged ventricle, most probably, that you can think that enlarged ventricle, because, I deliver the lecture on ventriculomegaly today, and ventriculomegaly may have the MCD. However, not all of them. We had recently 54 MCD cases. However, the only 1/4, 25% of them had the ventriculomegaly. Okay, so what? The brain size? Of course, that I told you that MCD, the first proliferation and apoptosis. Therefore, if the proliferation overdose excessive, of course, that might be the big brain. And the proliferation is less or apoptosis is much, maybe the small size. So this is, the literally reasonable to find the MCD. Of course, the brain size, however, not like simple thing, to see the MCD. This is the case at 31 weeks of gestation. This is a very abnormal line here. This is abnormal. You can say that this might be one of the schizencephaly. It might be, but this is very subtle. And usually, in the transabdominal sonography, cannot detect, this kind of abnormality. And I asked the MRI guy that, that I found this, so, please take this. Therefore, that they take this, but, somewhat, if you don't cut this brain, you can overlook, right? And then this one, the abnormal RG gyrification. At 20 weeks of gestation, usually the very flat and the no gyration yet. However, here you can see the very abnormal, very deep sulcus here. And also this is very asymmetrical structure. And 2 weeks later, you can see here, this is many of the gyral and the sulcal formation here. But in this side, there's no. So this is quite abnormal. And that was the P10 abnormality. And this one, is the irregular ventricle wall. This is 24 weeks of gestation. This is another case, 19 weeks of gestation. This is 20 weeks of gestation. You can see the very irregular surface of the lateral ventricle wall. And this is the heterotopia of the ventricular part. And sometimes here, the asymmetrical structure, you can see that here and there, the very asymmetrical structure, and also you can see the very abnormal Sylvian fissure here, right? And this is the same case, MRI, you can see the polymicrogyria here and there, and this is a very abnormal brain surface. Of course, you can find the MCD if you are close look, if you have the close look, and by transvaginal approach. However, I'd like to tell you the indirect signs of the MCD. The Sylvian fissure, medullary veins, Cattier line, and abnormal gangrenic eminence, not GE healthcare. Okay, so, and then the first is the waist. Okay, so everybody wants to become this kind of the very, very sexy waist, right? Girls? However, I would like to talk about, the brain waist. What is a brain waist? That is a Sylvian fissure. And Sylvian fissure, 18 weeks, 21, 25, and 30 weeks of gestation, there is a changing appearance of the Sylvian fissure, like this. And I told in the many lectures many years ago, I told about, the Sylvian fissure is changing. So, let's have a look at the Sylvian fissure. However, one day, Leona Pun, she's a very good friend of mine, in Hong Kong now, and she asked me, Dr. Poo, you can understand, this Sylvian fissure is wrong, this Sylvian fissure is okay, right? However, because Dr. Poo is the expert, so for the general OBGYN doctors, how they can tell this is wrong, this is good, and then we can, create the Sylvian fissure angle, okay? The Sylvian fissure angle like this, in detail you can go to this article, Leona Pun and me, and we had the normal assessment of the Sylvian fissure at 18 to 30 weeks of gestation. And also, this is the article, the next article in the same journal, the same volume, and the positive angle to the negative angle. This is there is a cutting point of the 0 degree from positive to negative angle of the Sylvian fissure angle. There is a 25 weeks. And here you can see the 25, and that is the very easily understand. So, if you don't measure the Sylvian fissure angle, you can see that this is a 25 weeks of gestation. Here you can see this is not the rectangular, and this is the normal rectangular. So, you can say that, oh, this is abnormal, the delayed development or premature Sylvian fissure. So many of the MCD cases, mostly, the more than 91% of the cases with the MCD, they have the different angle of the Sylvian fissure. The Sylvian fissure angle is much larger than the normal reference. And also, the 31.6% of them had the genetic disorder. At that time, this is the 2019, it was on the journal, so that this was before 2017. So now that we are re-scrutinizing the MCD of the exome sequencing, the whole exome sequencing, and sometimes we found the new variant in those cases, so the much more percentage of the genetic disorder. Now, the second one of the 4 indirect signs is the medullary vein. Here, this is the Okudera et al. In 1999, 25 years ago. And this is the only article for the fetal medullary vein. This is a superficial medullary vein. This is the deep medullary vein. They are coming from the surface, and they are from the bottom or the lateral ventricle, and there's the veins here inside the parenchyma. And here you can see this is the medullary vein. Here you can see this is the medullary. Those are the medullary veins, and then those are the lenticular striated arteries from the MCA, the medullary arteries. So here you can focus on those medullary veins. Okay. So at 16 weeks of gestation, you can see the red one. Red means going up, okay? But at 18 weeks of gestation, you can see the red plus blue. Okay, the blue means going down. And 21 weeks of gestation, the blue one is growing. And then the 24 weeks of gestation and 25, you can see the long, the blue ones. And then 30 weeks of gestation, the number of the veins are, they're increasing. And now this is a 16 to 30 weeks of gestation by slow flow. And you can see, that this is the development of the medullary vein. Now, we need the quantitative analysis, and we measure the subplate and cerebrum thickness, and also we measure the medullary vein length. And then here you can see this is the subplate thickness, the blue line, and this one is the cerebral thickness, and the medullary vein length is going along with the subplate thickness and suddenly go along with the cerebral thickness. What does it mean? Here you can see the incomplete connection between the deep one and the superficial one, right? And here you can see the complete connection because the superficial and deep medullary veins are shaking hand because of the anastomotic the veins. So we focus on the incomplete connection and complete connection. Now suddenly they connect completely, not gradually. This is the point of 25.6 weeks of gestation. Okay, so in normal cases. So therefore, we are focusing on the over 26 gestational week. The medullary vein, usually 26 weeks of gestation. Most of the case, they have the connection, complete connection, right? So going back, you can see the complete connection after 26 weeks of gestation. So what about the MCD cases? We saw the MCD cases, case 1, the 26 weeks of gestation, still not connected, right? So this is incomplete. And this one, 27 weeks of gestation, not complete, okay? And this one, 33 weeks of gestation. This side, connect. But here, incomplete connection. Here, this is no connection here. So we had more than 700 controls and MCD cases. And then the control group, mostly the complete connection after 26 weeks of gestation, but MCD, they have the incomplete connection at 75.8%. Okay? And the number 3 is a cat ear line. What is a cat ear line? So far, over 20 years, I looked at the brain, and then I looked at this line all the time by transvaginal neurosonography. What is this? And I asked many of the professors, the neurosonography expert and MRI expert. However, they don't know about that. And normal fetus, here you can see the line, the Cartier line, but MCD fetus, sometimes it is a very different shape. And Dr. Nana Masazawa, one of my students, we have the article, published the article, and the first definition is CAL is like this. This is a CAL, Cartier line, and here this is the pre-CAL, only in the subplate, okay? And this is the abnormal CAL, and then the CAL is observed in the same point as the Sylvian Fisher angle, and then we have the data and the first, the no visible CL to the pre-CL and pre-CL to the CL like this, okay? And we had the data between the control group and MCD, and MCD is delayed. The Cartier line development is very delayed. Pre-CL has been observed in 60%. And also, the abnormal CL, right, like that is only in the MCD group. And here you can see this is the case of the cytomegaloviral infection. You can see the persistent pre-CL and abnormal CL in the other side. So this is a summary slide of the normal CL development and the CL maldevelopment, okay? And we have the very rare case. And here you can see the 26 weeks of gestation. You can see the very abnormal, premature Sylvian Fisher. And this is the BPD is minus 3.3 and the HC minus 3.8 standard deviation. This is a completed very small brain, a small head. So small head with the very premature lissencephaly-like the structure, so we can call that the microlissencephaly, and we had a strong suspicion of the TUBA 1A, the tuba 1A, and I asked the very rapid WES in the several days. However, there are negative results of the SNP microarray and the WES. However, we look at the brain, here, no development for 4 weeks, okay? So those are the same gestational age, but here this is a case, 26, 28, 30 weeks of gestation, no development at all. And here you can see this is a Sylvian Fisher angle, nothing happened, no change. So now, we were at a loss. What is this? And then we had the cytogenetics result. Usually, molecular genetics result is normal, the negative. We don't think that, cytogenetics, cytogenetics, okay, so just in case. But just in case. Here you can see that this is a very abnormal metaphase image and various karyotyping, the many kinds of trisomies here and there. So this is called the PCS-MABA syndrome. This is the cancer-prone, and the incidence is 1 out of 1 million. And here, this is a very, very abnormal. The baby has very poor prognosis because the baby was born and then many of the cancers, malignant cancers, are coming out one and another. And then, usually, this is very, very bad prognosis. But PCS-MVA syndrome is one of the BAB1B gene abnormality. So, the BAB1G is related to the separation of the chromosome, okay? So we re-scrutinize the BAB1 gene, and this is the exon. The paternal variant was in exon, however, maternal variant was not in the exome, so therefore, the exome sequencing couldn't realize that, the maternal variant is in intron. Anyway, the baby was born, 36 weeks of gestation, 2,300 grams, and they cherished the baby, and so far, it's so good. However, 90 postnatal day, May 19th this year, this is the 3 months. At that time, that they came to me, and I was very happy to see them. However, Wilms tumor was found 2 days before, and then, however, parents opted the best supportive care, no chemotherapy and no treatment, the medical treatment. And then, 3 days before coming here, the 147 postnatal day, the July 15th, they came back to me, and we had the parties, the small party for them, the welcome back, and then, however, Wilms tumor became very huge and easily palpable by hand. And they are thinking that most probably next month, they don't have the next month with this baby, so they are cherishing the baby, and they travel a lot here and there, and they have the memories, but I would like to see him, one more time, within his life. But anyway, that this is the story of the microencephaly baby, but no reports, no article so far with the PCA-MVA syndrome has a brain abnormality. So every the baby with that syndrome has been found because of the cancer. Therefore, the 2 more doctors, they are treating next, the chemotherapy, and then next cancer is coming out, the chemotherapy, and next one is coming, so that their life is a disaster. Okay. And lastly, the gangrenic eminence, not GE healthcare, that this is the GE, the gangrenic eminence. This is the birth rate of the interneuron, and this is the migration direction is different from the normal neuron. And the gangrenic eminence is thinner and thinner during the pregnancy. Okay? And I had the case, again, that this is a 2015, and there's a somewhat abnormal at 19 weeks of gestation. There's a cyst, and I send the patient, the pediatric neurology specialist, but she said no evidence of abnormality. So they continued the pregnancy. At that time, we didn't have the West exome sequencing, so they went to continue the pregnancy in 23 and 25 weeks of gestation. Everybody knows 25 weeks of gestation. The Sylvian Fisher, very abnormal, right? And this is a microencephaly, and this is the TUBA1A abnormality. However, when I went to Vienna for studying MRI, and this is the Gregor Kasprian, and this is the Daniel Preyer, and this is the #1 team of the fetal MRI, the fetal MRI in the world. And I asked Gregor that, what do you think this is at 19 weeks of gestation? And surprisingly, he said, was this a case of lysencephaly? Oh my gosh, how come you know that? And this is 9 years ago, and then this is my oh my god case, right? Therefore, after this, I studied the gangrenic eminence. And gangrenic eminence in the normal case, at 14 weeks of gestation, 20 and 26 weeks of gestation, like that article, that is thinner and thinner. And sometimes, that we have the case with a persistent gangrenic eminence, and also, in the persistent gangrenic eminence, there is a cystic area that might be the cavitation or something. Here you can see this is a very abnormal, the persistent gangrenic eminence, and this is also the gangrenic eminence in other case. This is a monogenic disorder, and this case, I showed you, this is the oh my god case in my life, and this is the other case, copy number variant. This is a Jacobsen syndrome, and you can see the cystic area inside of the persistent gangrenic eminence, and this is also the gene variant. At 19 weeks of gestation, you can see the cavitation within the persistent gangrenic eminence. So we have to look at the gangrenic eminence, and also that this is influenced the MCD. So from my experience, from the oh my god case, that we found the Sylvian Fisher angle, Katia line, and the medullary veins and the gangrenic eminence. So you have to look at the brain very carefully, and then that you may have found some of the MCD cases. But lastly, last but the not least, the somatic variant mosaicism. Sometimes the obvious MCD suspicious and the genetic disorder, and you do the amniocentesis and exome sequencing and find gene variant. In this case, you can say that germline variant. However, if you do the same thing but negative result, you give up to think about genetic variant. Sometimes there's a somatic variant of the brain, but usually that is confirmed by the neurosurgeon. And the interactive epilepsy and surgery, and then they take out the brain, and then they found that genetic sequencing abnormality. And the somatic variant occurs because of the timing and the region. And I would like to show you one case. The 20 weeks, BPD was 2.8 standard deviation and HC plus 3.7 standard deviation. And here you can see the asymmetrical brain structure and polygyria here. And this is the abnormal irregularity of the brain, the lateral ventricular wall. And this is a preventricular heterotopia, and we did amniocentesis, but everything was normal. Okay. However, they decided to terminate the pregnancy. You can see the very abnormal brain size here, and also here you can see this is a histology, and this is a polymicrogyria here and there, and here this is the persistent gangrenic eminence. And also here you can see the subventricular heterotopia and the other the pathologic the histology is here. Now what we did was to take out the brain tissue from the left and right, and also we took heart blood and cord blood and placenta, and the amniotic cells and maternal and paternal the blood, and those are all negative. However, the right brain, 43.8% of the AKT1 mutation. This is one of the mTOR pathway gene, and the left brain, 40% of the AKT1 mutation. So this is exactly the somatic variant mosaicism. So it is, that it exists. So maybe you have to think about that. Okay, to wrap up, the fetal cortical development, the many MCDs are detectable at mid-gestation, and Sylvian Fisher is very important, and transvaginal neurosonography or MRI is a must, and the longitudinal NSD neurosonography follow-ups, and genetic investigation, and no variant possibility of the somatic mutation mosaicism, and cytogenetics may cover the pitfall of the NGS. That is I showed you the PGs, the case of the cancer, right? So I would like to say the neurosonogenetics is very, very important. And lastly, I would like to talk about the 4th annual Congress of the JSWOG. We have the Japan like ISWOG, Japan Society of Ultrasound in OBGYN. And next March, we have the Ravi Chawi and Shenli Li from China, and Leona Boone and Dr. Jai Yong-ki Kwon, and to Osaka. And Ravi Chawi is first come to Japan, and we will have the hands-on session. So everybody, you can meet with Ravi and Leona and myself, and then we can have the live scan like this, and then we can have the transvaginal neurosonography hands-on. So you can do hands-on with the patient, and with the guide by the Ravi Chawi and myself and Leona Pun. And then this is an on-site 60 participants for pre-congress, 14th of the March only. So maybe if you are interested in, you can go to this website, and then the early bird registration is coming from the August 1st till Christmas. Thank you very much.